So step 5 is we have to find the cases systematically. To find these cases, we need the role of hospitals to review the admissions and inpatient records, the clinics where we check the outpatient consultation logs, laboratories, the cross-reference test positive results, community surveys actively canvass the affected areas, and mortality records to identify the outbreak-related deaths. So this surveillance can be active and passive as well. Active surveillance is the one where the investigators actively search for cases, and this is more complete and resources are used intensively. But passive surveillance is the one where cases are routinely reported already to the healthcare facilities, and this is less sensitive and less costly. Then line listing, where this is actually a table which includes the ID number, which is a unique case identifier, the age and gender, the demographic variables of the patient, address to map the cases according to their residence, the date of onset, that when symptoms begin, the exposure history, which is the possible source of infection, and the outcome means the patient recovered, hospitalized, or died. Then the next step is a descriptive epidemiology. That who is affected, the person, and the factors like demographic, the risk behaviors, and socioeconomic factors are mentioned. Then where the disease occurred or the outbreak occurred, the place, the geographic clustering. We have to spot the maps and GIS mapping. The environmental context is given in this. And then when the outbreak occurred, for this we made the epidemic curve, which was discussed in the yesterday's class, the incubation period and the exposure window. All of these are included in the time analysis. So analysis by time, we estimate the incubation period. And as mentioned earlier, this is performed using an epidemic curve. We identify the exposure period, um, and then we determine the outbreak progression. We track how the outbreak is evolving over time. So analysis by place, we spot the maps, we plot the individual case locations, and GIS mapping can be done to layer the geographic and case data. The heat maps can be made to visualize the density of cases across an area. Then analysis by person, we mention their age, their gender, their occupation, their risk behaviors, and the socioeconomic factors. Then the next step is we have to develop the hypothesis, proposing an explanation grounded in the descriptive findings. So I hypothesis a proposed explanation for the outbreak. It should explain the source of infection, the mode of transmission, and the population at risk. So the sources of hypothesis can be the interviews which are done with the cases and their contacts, the site visits, means we went to the field and directly observed the area, the clinical observations, the patterns noted by the clinicians, the laboratory findings which are, and the case outbreaks means the lessons learned from the prior events. So example of hypothesis is the consumption of contaminated drinking water from a well caused the outbreak. So this is a useful hypothesis, and it should be specific and testable. Then after making the hypothesis, we have to evaluate it, testing the proposed explanations with analytical epidemiology. So after the descriptive epidemiology, now we have the analytical portion, where we can use different study designs or methods of analytical epidemiology, like cohort study. This is used when the population at risk is known and frequently used in the foodborne outbreaks, and the main measure is attack rate and the relative risk. Case control study, this is used when the population at risk is not clearly defined. So cases are compared with the controls, and the main measure is odds ratio. So interpretation of the results according to whatever study design has been used. We see the magnitude of association, how strong is the relationship, the statistical significance means could the finding be due to chance only, biological plausibility, does the finding make any biological sense as well, consistency with the descriptive findings, does it align with the time, place, person picture? So we have to answer all of the questions. And then the next step is we have to reconsider, refine, and re-evaluate the hypothesis. We conduct additional interviews when initial hypothesis doesn't explain all the findings. We review the collected data, we re-examine what has already been gathered, and explore the alternative exposures. We consider explanations not yet tested and generate new hypotheses. Means outbreak investigations are often iterative. This will refine the investigation. New information may reveal exposures or transmission routes missed in the first pass. So previously unrecognized exposures or alternative transmission routes or additional risk factors. All of these are gained by this step. Then we compare and reconcile with the laboratory findings. We strengthen the conclusions with lab and environmental evidence. We can use culture to isolate and identify the positive organism. PCR can be used for molecular detection of the pathogen. Serology can be used to detect immune response to infection, and molecular typing to confirm the strains are linked to a common source. Environmental investigation should be done where required, like water contamination to find the source and distribution, food handling deficiencies like preparation and storage gaps, poor sanitation can be investigated like waste and hygiene conditions, and vector breeding sites should be investigated to see the conditions which can be favorable for the disease control. So integrating the evidence, epidemiological, this portion included descriptive and analytical findings, then laboratory, which confirmed our diagnosis and test results, and environmental, which helped us finding the source and contributing conditions. So next step is we have to implement the control and prevention measures. Control measures should begin as soon as sufficient evidence becomes available. Delays may result in preventable illness and deaths. So levels of intervention can be that we control the source, we remove the contaminated food, for example, and treat the infected person. We can interrupt the transmission, like we can do isolation, quarantine, and sanitation measures, and protect the susceptible persons by doing vaccinations and chemoprophylaxis. These are some examples of the control measures. Like in case of cholera, we can focus on the water chlorination. In case of measles, the vaccination campaigns. In dengue, we go for vector control, and in COVID-19, we preferred isolation. Next step is initiate or maintain the surveillance. So watching closely to confirm the outbreak is truly under control. So for this, we detect the additional cases by enhanced surveillance catches what routine systems may miss. We monitor the trends. We track whether the outbreak is rising or falling. We evaluate the interventions to confirm that control measures are working. We identify the recurrence and catch any resurgence early. So objectives of continued surveillance is that has the transmission stopped? Are the control measures effective? And are the new clusters emerging or not? The next question is when is an outbreak over? We will label that outbreak is over when there are no new cases, incubation periods have passed, the source has been controlled, and surveillance data confirms the interruption of transmission. Probably this is the last step that we have to now communicate the findings, translating evidence into public health action. So, communicating findings is important to the health authorities, to the policy makers, healthcare workers, communities, and media. And then we have to prepare the outbreak report, and that has to be communicated to all of the relevant people. The report has following components like background, objectives, methods, results, discussion, limitations, and recommendations. Risk communication, which is the effective communication, should be timely, accurate, transparent, and action-oriented. So this was a summary of all of the steps, and definitely there is a detail of each of the steps, but I tried to cover it in this short time. Now we come to the MCQs. Question number one: a village reports 40 cases of acute diarrhea within 2 days. What should be determined first? Option number one: relative risk. B: existence of outbreak. C: odds ratio. D: case control study. And E: surveillance sensitivity. So we have to confirm the existence of outbreak. Question number two, 20 students develop vomiting after a school lunch. The investigator first confirms the diagnosis by option A, spot mapping, B, case finding, C, laboratory testing, D, cohort study, and E, surveillance.
B.
C, laboratory testing to confirm the diagnosis. Question number three, an investigator defines a case as any student with diarrhea from 1st to 7th August. This is called option A, line listing, B, hypothesis, C, case definition, D, surveillance, and E, attack rate.
C.
Yes, this is case definition. Question number four, 30 patients with hepatitis A are identified through house-to-house visits. This is option A, passive surveillance, B, sentinel surveillance, C, active surveillance, D, syndromic, and E, laboratory surveillance.
C.
Yes, C is the right answer. Question number five. Investigators suspect contaminated well water caused the illness. This suspicion is option A, conclusion, B, recommendation, C, case definition, D, hypothesis, and E, diagnosis.
E.
D is the right answer. This is their assumption. Question number six. A wedding guest list is available for all attendees. Which study design is most appropriate? Option A, ecological study, B, case control study, C, cohort study, D, cross-sectional study, and E, trial.
C.
Yes, is the right answer. Question number seven. A suspected food item shows no association with illness after analysis. The next step is option A, end the investigation, B, publish findings, C, refine hypothesis, D, start vaccination, and E, close surveillance.
C.
Yes, C is the right answer. Question number eight, investigators find a leaking sewage pipe contaminating a water supply. This is primarily option A, analytical evidence, B, environmental evidence, C, clinical, D, surveillance, and E, statistical evidence.
B.
This is environmental evidence. They found it in the field. Question number nine, no new cholera cases occurred for 2 incubation periods after intervention. The main purpose of continuous surveillance was to option A, verify diagnosis, B, develop hypothesis, C, identify controls, D, confirm outbreak control, and E, calculate odds ratio.
D.
D is the right answer. Question number 10, during
D.
a measles outbreak, vaccination is started before the investigation is complete. This illustrates option A, descriptive epidemiology, B, risk communication, C, control measure implementation, D, hypothesis generation, and E, case finding.
C.
C.
Yes, C is the right answer. This is the answer key to all of the questions. This is the YouTube channel of IPH where this presentation will be uploaded. And thank you so much.
Thank you so much, Dr. Aamna. It was a very good presentation.
Thank you, Dr. Aamna.